Yeah, so CPX, changed the standard of care for secondary AML patients, where clearly survival, particularly patients who went to transplant, is much better than with 7+3. Actually, we'll hear at this Congress, CPX is also better than FLAG-IDA, particularly for these secondary type mutations. But then the big question is why? I think a lot of hypotheses was, does this lead to deeper MRD negative remissions post-transplant, or is it something else? Is it that it's in general better tolerated? Really open questions. So I think going into the study, we said, hey, CPX should lead to a very high degree of MRD negativity rates, not by flow, which has been published, but by deeper sequencing, this error-corrected NGS panel. I think kind of to our surprise, it's actually quite rare to clear all your mutations, at least down to that 0.1% level. So even excluding DTA, which was really not an impact, we only had several patients that completely cleared. Now, for what it's worth, those patients did do great. One of them was an NPM1 mutant patient and was cured with just CPX therapy by itself. So not a lot of patients having deep clearance, and really supports that, hey, these patients need to go to transplant or they're going to relapse. I think what we found that was really impressive was that patients that got CPX went to transplant, if their post-allo specimen was MRD negative by error-corrected NGS, their outcomes were really impressive. We actually only had one patient out of the total cohort. It wasn't huge, but eight or nine patients, but only one relapse. So I think it's a really cool biomarker that, hey, if day plus 30 you are error-corrected NGS negative, you did remarkably well.